Cord to the cloud. Got it. I found him, so he's in. So can you see that or not? I don't think so because I've lost all of you. Okay, everybody see anticholinergic bronchodilators? I think I got it fixed here. Everybody got that okay? Okay. So, we've been talking, I'll go back a couple slides just to kind of bring us up to date here with the medications. Did you find, I sent you a list of sort of a cheat sheet with bronchodilator drugs on it and anticholinergics and how they all sort of fit together by category?
Yes.
Yeah, did everybody find that okay? It was under shared references. I sort of typed it up for you just to kind of have that. So when we talked about sympathomimetic drugs, we talked about the 3 categories, and the non-selective hit alpha, beta 1s, and beta 2s. So you got effects doing that, and the drug in that category is epinephrine. And then we talked about non-selective adrenergic betas, which means that it hits beta 1s and beta 2s. So that you get this short acting because it's metabolized by the enzyme COMT. And so that's why they call them short acting beta agonists. And then there were selective beta 2s, and there were 2 types of those. The ones are the catecholamine. And the catecholamine ones, what happens with that is that when it makes a catecholamine bridge between the beta receptors, catecholamines resemble epinephrine by chemical structure. So what happens is COMT eats that so that they're very, kind of short acting. So then they came up with the idea, well, let's make them non-catecholamine. In other words, what happens is chemically, they don't look like epinephrine, although they have the same action. So that when the non-catecholamine meds create the bridge in the beta 2 receptors, COMT does not recognize it as a catecholamine, therefore leaves it alone, which allows more medication, if you will, chemical neurotransmission to occur. So therefore that makes them long acting. So that's the difference. And I didn't know, a couple people asked me about that, and I wanted to make sure that you sort of got that okay. Do you have any questions about that? So those are the pure bronchodilators. Pure bronchodilators work on beta 2 receptors. So, and if you remember when we talked about the sympathetic nervous system, we said, once you stimulate the sympathetic nervous system and cause the release of epinephrine, the parasympathetic system comes in and goes, oh, I want to bring you back to normal. So what I'll do with that is I'll release acetylcholine. Acetylcholine is a cholinergic neurotransmitter, and it tries to check and balance the sympathetic system so that you don't get long-term bronchodilation as a result, because it sort of goes in and blocks the epinephrine. So they came up with an idea of, well, let's block acetylcholine from eating up epinephrine, therefore it would extend the bronchodilation from epinephrine. So the medications for that are the Atrovent, Spiriva, Trudorza, and Ellipta. And you might have seen, these are anticholinergic meds. They're mostly all given by inhalation. You can see the Atrovent is a meter dose inhaler. Spiriva is a Respimat. They put the medication in and it mixes and spreads it out. But anyway, So that when a patient takes an anticholinergic, what it does is it blocks acetylcholine from coming in and trying to get rid of or balance out epinephrine. So therefore it prolongs bronchodilation. And you know, and somebody asked, we were talking about in the ATI videos, it talked about anticholinergic being bronchodilators. Well, they're not technically bronchodilators. They are, they block acetylcholine, so they're anticholinergic. But what they allow is for longer bronchodilation due to the blockage of acetylcholine on epinephrine.
By blocking, I'm sorry, Dr. Hess, by blocking what?
Acetylcholine.
Okay.
They're anticholinergic, so they block acetylcholine. Because acetylcholine is the neurotransmitter for the parasympathetic system. And it's the only neurotransmitter. So what they do is they block that and thereby allowing for longer bronchodilation, but they are not in and of themselves true bronchodilators. The only true bronchodilators are the beta 2 agonists.
So what would be a case that you'd take the anticholinergic?
Almost everybody takes one. With the COPDers and a lot of times with asthma, because it does allow for longer bronchodilation by blocking the acetylcholine from affecting epinephrine. And remember, epinephrine is what causes bronchodilation. So if you can manage that, then so, and that's where a lot of these medications are what, you know, one of the ones we use is Combivent. Combivent is a combination of a beta 2 agonist and an anticholinergic. So they take it in one medication. So many people take anticholinergic medications to prolong bronchodilation from a beta 2 agonist.
In one of the YouTube videos, I think I shared in the pharmacology group, the guy talks about how you follow like the 3 steps of the medications, and he uses the acronym AIM. So you'll use albuterol, then you'll use ipratropium, and then you'll use something that starts with an M. I can't remember, but it's basically like if you use albuterol first, which is a bronchodilator, then you take the ipratropium, which blocks the cholinergic receptors, allowing the bronchodilator to work longer and better.
That's exactly right. So, and that was my next point. So thank you. Because when if you're taking these meds separately, you always take the bronchodilator first, because what happens is you want that effect of bronchodilation. So the next thing you take, you have better airway to get the stuff in there. So you take the bronchodilator, like, you know, the albuterol, take that, and that causes the bronchodilation because it's a beta agonist. Then once that happens chemically in your lungs, what happens is you've got bronchodilation. The parasympathetic system says, oh my God, no, we better send out acetylcholine to bring you back to normal. So then you take the Atrovent to prevent that from happening. So that prolongs bronchodilation. Does that seem reasonable or clearer or not? Yes. Okay. Sure. Kind of thing. So you kind of taken care of 2 things. You've caused bronchodilation by stimulating the beta 2 receptors. And then you've also blocked acetylcholine in the parasympathetic system to maintain bronchodilation. So those are you know, 2 very important concepts for people with any kind of airway problem. The one thing with Atrovent too, I don't know that I've done some, you know, some literature kind of thing. If people have a peanut allergy, they tend to have a little trouble with Atrovent. So that's one thing to keep in mind, to ask people if they have a peanut allergy. Apparently there's some chemical in this medication that precipitates that effect. So just kind of be watching, ask about that.
The drug book also says soy, if they're allergic to soy.
Just soy. Yeah, there's something that holds. So Atrovent does have a little bit of something that you want to be careful of with patients using that. So, okay. Any questions about, beta agonists, anticholinergic bronchodilators at this point? Is everybody kind of clear on what they do and how they work and what we would give patients? I mean, we wouldn't get, we don't prescribe them, but I mean, we would know that what we were giving patients for that.
I just have a quick question from the
Sure.
first slide.
Yeah.
I was reading breathing is no longer used in the US.
Might not be. It's tuberculin, and they have a newer medication. They use it, breathing by itself is not. But there's a tubulin out there that they have sort of replaced that with. So, okay, that might be. I've not seen that in the literature, and the book still talks about it, so I'm not sure. So we'll, I'll check, I'll look out on the FDA thing. But they're up, they're constantly upgrading these medications and coming out with combination meds for patients. There's a new one out, I just saw it on the TV the other night, Dupixent, which is a respiratory med for COPDers that is a combination med of a bronchodilator and an anticholinergic. So that's a brand new one. So they're coming out all the time with new medications for this. Any other questions or things anybody wants to ask at this point? So another category, okay, this new category, are leukotriene antagonists. Now, antagonist means that we're going to work against leukotrienes. Leukotrienes are a chemical in your body. What they tend to do is they tend to make mucus, allow mucus production, and, for mucus plugs and all those kinds of things. And they also act as an inflammatory action. So if you can block leukotriene, you do two things. You decrease mucus production and you have some anti-inflammatory activity. It's also related to the production of prostaglandins, which we know is, very inflammatory kinds of stuff. So leukotriene, these are used primarily for, you see them sometimes with asthma and also with allergies. So that you'll see, kind of things. And there's 3 of them on the market at the moment. Does anybody, sometimes, students will say, oh, my kids are on that. Has anybody got anybody on it or? Yes.
No, I'm just saying I'm actually on Singular and I'm on,
Okay.
2 different ones.
Yeah. Okay. And does it work pretty good for you? Did you notice a difference or?
As long as I stay on them.
Yeah. Then that's the issue, because once you stop taking them, the leukotriene has no reason not to make, because it's a natural product of the body. So so that's an important aspect of these medications, is make sure you take it at the same time every day, so that it stays working in your body. There aren't many side effects to them. They tend to work pretty well. Again, as long as you take them every day.
I take them actually separate. One's an AM med and one's PM.
Okay.
So,
You get a good round the clock coverage with some of that. Okay.
yeah.
So those are the leukotriene antagonists. And again, they aren't used an awful lot for COPD, but they are used for some asthma and allergy kinds of people that have symptoms with that, because it does help with mucus production and as a little bit of an anti-inflammatory. The next drug is what they call methylxanthine, and it's called the bronchodilator because it acts sort of the same as an anticholinergic does. I'm gonna go out. I drew something last night on the whiteboard, and I want to see if I can pull it up for you to show you what happens with this. So hold on just a second here as I not sure I can find it. Can you see that?
Yeah.
Okay. So this was a whiteboard drawing I did last night, and I kind of, and it's really sloppy, but I don't do good with mouse drawings. So anyway, so I wanted to show you this, and this is related to methylxanthines. So what you have here, this is a bronchial smooth muscle cell. Here are the beta 2 receptors because we are in the lungs. So you have beta 2s. And here's your sodium and potassium, although my N didn't come out very well, but sodium and potassium. So that creates the action potential for either in this situation, bronchodilation. So sodium and potassium come to the beta 2 receptor, and it makes, the epi bridge that we talked about, or the catecholamine bridge, or whatever's out there. And epinephrine is referred to, or that bridge effect is referred to as the first messenger. So what happens is then the sodium and potassium come into the cell because they cross the epi bridge, and they produce a chemical called cyclic 3,5-AMP, which stands for amine monophosphate. Amine monophosphate. Cyclic 3,5-AMP is actually the second messenger. That technically, pathophysiologically speaking, is the chemical that causes dilation in the bronchial smooth muscle cell. So epinephrine is really only the first messenger. The actual chemical that causes that is the second messenger, cyclic 3,5-AMP. Once the body senses that cyclic 3,5-AMP is in the cell, it sends an enzyme called phosphodiesterase. And again, I'm sorry it wasn't written out very well. Phosphodiesterase. And phosphodiesterase comes in and it eats cyclic 3,5-AMP. When it eats the cyclic 3,5-AMP, the bronchial smooth muscle cell goes back to its normal state. So again, if I want to maintain bronchodilation, I could give a medication that blocked phosphodiesterase. If I block phosphodiesterase, I will maintain levels of cyclic 3,5-AMP, or the second messenger, which maintains bronchodilation of the cell. I'll stop there and see if you have questions. Does that make sense to you, kind of thing? So it doesn't cause bronchodilation, it maintains what is there. by allowing the chemical cyclic 3,5-AMP or the second messenger to be available.
But that's only if it's blocked by the phospho.
Yes, that only happens if you give a medication that blocks phosphodiesterase. Does that seem okay, or everybody okay with that? Questions?
The
Methylxanthine,
there you go. That's
Yeah.
the only one that does that
it blocks phosphodiesterase, which I'm going to
phosphodiestine and increases the 3,5-AMP.
AMP. That's absolutely right. Yep. And I'm gonna come back to that in a minute. I just wanted to make sure everybody kind of had a sense of what this looked like. Now, remember we talked about COMT. COMT works right here to eat epinephrine. That's where COMT works. And then also off the bronchial smooth muscle cell, you have parasympathetic or cholinergic receptors, and they produce acetylcholine, and we talked about giving an anticholinergic to prevent that from happening. So the other medication that we can use is methylxanthine, because it will block phosphodiesterase, because that's an enzyme that will eat cyclic 3,5-AMP. So the whole idea to these medications is to block things that cause bronchoconstriction. And that is COMT, which allows an epibridge, acetylcholine, which will cause bronchoconstriction, and phosphodiesterase, which eats cyclic 3,5-AMP and takes you back to bronchoconstriction. Yes, no?
So basically there's like 3 ways to
Yes.
increase bronchodilation.
Yeah. Mhm.
Blocking the
We block COMT by giving a non-catecholamine medication. That
an
means,
anti-chloride.
yeah, we'll give an anticholinergic to block
Yes.
acetylcholine, and then we'll give a medication that will block phosphodiesterase.
Okay, thank you.
Yep, does that seem reasonable? Sort of?
Yes.
So
Okay. Yeah.
in this train of reactions, is this where it goes from the short acting to the long acting?
Right there it does. Yes, right here for the medication.
Right, that's the short acting, but then
Yep.
when you get all the way down to the phosphorase,
Phosphodiesterase?
yes,
Mhm.
to block. No, wait. But
it
if you
doesn't-
have the phosphodiesterase to keep, oh, now I got confused. But if you
Okay.
have that, then now we're long acting.
Not by category, only by
Oh, okay.
action.
Maintaining.
Yeah, you're maintaining
Maintaining.
something that the drug has created. Yes.
Okay, so this
Yeah.
is just to maintain. Okay,
Yes, it's a maintaining. It doesn't cause.
Yeah. Because you have this medication is a maintenance drug then.
Yeah, more or less. Yeah, you could consider it more of a maintenance, because you have, if you have bronchodilation over here caused by the epi-related medication and a beta-2. So I'd like to maintain that because I want bronchodilation. So if I give an anticholinergic, I block acetylcholine. And if I give a phosphodiesterase blocker, then I allow the accumulation of cyclic 3,5-AMP, which maintains my bronchodilation.
So if we block the, was it COM or
PT. You don't,
Then
that is a you don't block that in respiratory. What you do is you give a medication that COMT does not recognize as epinephrine chemically. So therefore
Okay.
we'll leave it alone. So that maintains your bridge, which allows the action potential to maintain bronchial smooth muscle cell dilation.
Okay. So is this maintenance like a first choice, or we're more likely to do the one that isn't the chlorogenic one so that we have the long acting?
Yeah, this medication, let me tell you about the medication. And then I'll tell you, then you'll figure out why this medication is not used a lot.
Okay.
Because of its side effects. It has these really bad side effects. So it's not used a lot. So therefore we tend to rely on a beta 2 agonist and an anticholinergic because you have less side effects than you do with a medication that blocks phosphodiesterase. So does that okay?
Yes. I'm just
Okay.
trying to
Yeah, oh yeah.
in my head.
So let me go back out to share screen and see if I can get back to the slide that we were looking at. So this is methylxanthine. And it's a category of drugs. They're bronchodilators, but not by action, only by blocking phosphodiesterase. So if they don't cause bronchodilation, they allow it to happen or maintain itself already by blocking phosphodiesterase. So when you do that, you increase levels of cyclic 3,5-AMP, which we looked at on the slide before. So a student drew this for me, so I thought it was kind of a nice thing. So here is phosphodiesterase down here. Here's cyclic 3,5-AMP. And here is the medication theophylline. Theophylline aminophylline is the medication. So the medication protects cyclic 3,5-AMP by blocking phosphodiesterase. Now, aminophylline has a lot of issues. If you were going to give it IV, we don't use it much anymore because of its side effects. You have to add it separately and administer it separately IV. If you're going to use it IV, it does come in PO meds, but so that's one of the things. It's incompatible with everything in solution. If you get toxic, and the toxicity levels for aminophylline are 10 to 20 UGs per milliliter. 10 to 20 is the therapeutic level. And if you get over 20, then you're considered to be toxic. The antidote for toxicity is Ipecac syrup and activated charcoal. So it's relatively difficult to maintain the therapeutic level without pushing people over in toxicity. If you're going from an IV to an oral therapy with aminophylline, then you have to wait 4 to 6 hours before changing that over. What aminophylline does when you take it, it breaks down into caffeine in the body. It's like drinking a gazillion cups of coffee. And what does that do to you? Stimulates. These people sort of hang off the ceiling. They're jittery. They talk fast. They do it. So you can, there was a physician that took this, and I used to tease him about, oh, did you take your aminophylline this morning, kind of thing, because he'd come in and he would just be flying around because it breaks down into caffeine. So that is a problem for a lot of patients, particularly if you have any cardiac issues, to have that much of this medication on board. So it's important that you limit coffee, tea, and cola beverages that have caffeine or, carbonation caffeine in them. And also charcoal broiled foods, because what happens is charcoal is the antidote. So if you cook out a lot on charcoal and you get charcoal stuff on your meat, it will inhibit the action of aminophylline. And one of the problems that people would talk about is we don't have one anymore in Watertown. We used to have a Ponderosa steakhouse here, and they cooked over an open flame. And people would go and then they would come into the emergency room and say, oh, you know, my aminophilin's not working well and all that's because they were eating these charcoal broiled foods. You have to be careful in patients with a history of peptic ulcer disease because of all that caffeine and stimulation it produces and increases the amount of hydrochloric acid. And it does cross the placental barrier and causes a buildup of caffeine in the newborn. So this is not a med that you should use in pregnancy for the most part. So the interesting things with this medication is that it works well by blocking phosphodiesterase. However, it has a lot of side effects, so therefore is not as effective as some of the other meds. So it's not used very much. And it sometimes where you might see it used is in kids with asthma. They might use it, but it makes them so wild that most of the time, and it comes in Theodore sprinkles where you can sprinkle it on their food. It comes PO, it comes liquid, it comes IV, it comes in a lot of ways, but the caffeine is a real problem. And the more you take of it and the more caffeine you get, the more jittery, heart rate, all those kinds of things. Questions about theophylline, aminophyllin?
So these side effects and things that you need to be careful when administering the med, that's for all methylxanthine?
All methylxanthine type drugs, yes, they all do the same thing. Yes, they all break down into caffeine. Yep.
And the antidote, I guess, is the same for all of them?
Yes, it is.
Okay. Just checking.
What was the toxicity level?
Toxicity levels over 20. Therapeutic is 10 to 20, toxicities over that. The other thing with these meds too is that I didn't mention, I don't have it on the slide, but I'll tell you, is the fact that theophylline and nicotine compete for the same receptors. So people that smoke have to have usually twice the amount of theophylline in order to maintain a therapeutic level. So that's one thing you want to check if you're going to be in a situation where you're going to talk about somebody with using theophylline is do they smoke? Or use nicotine, even vaping, because a lot of those vape things have nicotine in them. So that would make a difference. Any questions related to that? I just put this slide on here to show you shouldn't be cooking on your grill. Gas grills are okay, but you can't use charcoal.
I was just getting ready to ask that, just to clarify.
Yeah. Air fryers. Those are the best things. Put it in an air fryer and cook it up. They work well.
Yes.
Okay. So does that make sense in terms of a drug category, how that works to help maintain bronchodilation?
Yes.
Yeah, that's it. I can't see you all, so I don't know. So what this med does is it blocks phosphodiesterase, which maintains level of cyclic 3,5-AMP, which is the actual chemical that maintains bronchodilation in the bronchial smooth muscle cell. Okay. There's a new medication, a phosphodiesterase inhibitor. These are a fairly new classification of medication that comes out here. Let me go back and share something. I just was thinking about this, and I don't have a slide on it, but I wanted to tell you how many of you have heard of Viagra or Cialis?
I have.
Yeah, okay. These drugs are phosphodiesterase inhibitors. They're a little bit different category than this one, but what they were a medication that was originally designed, Viagra was originally designed for patients with severe COPD because it's a
Was an
phosphodiesterase.
erection.
Pardon me?
And they found out like a side effect was an erection.
Yeah, well, not a side effect. What happened is the side effect
Relaxed him.
is vasodilation in certain areas of the body.
So it increased the blood flow to their
yes, it increased
cranial
blood
area.
flow to the penis and also to the vaginal area. So you had so people went, oh, so in the beginning, it wasn't approved for erectile dysfunction issues. So we had people on Viagra for women with COPD. And for some of the nurses, they would go in and they'd go, are you sure you're supposed to be taking this stuff? It's not really designed for, but that was its original intention, was for COPD. And now it's not used for that at all. It's used primarily for erectile dysfunction. But if you have COPD, it does help with that. And every now and then you will have a patient that it works well for, and you will see them on that med. And it's not for erectile dysfunction, it's for their COPD.
So usually like with Cialis, because I would have to do like prior authorizations for them to have it like every day at a low dose.
Yep.
But it was for ED because
Oh, okay. Yeah. It's
because
along the
Cialis
same
at a low
idea. Yeah.
dose, like the 5 milligrams per day, gave them more of a chance to not be so, or they were able to be more spontaneous instead of
Yes.
just having like a couple of times a month that they could and they had to take the pill and give it the time to react and blah blah blah. So was Cialis like the same way? Was the COPD before it became the ED thing?
Yep, it is, because it has the same action to it. So that was Viagra was the first one, and then found that out, and then they added Cialis. But we don't. It is for, you can use it for COPD, but you can use it for other stuff as well. So I just kind of wanted to mention that to you, because if you're in the hospital and you do see somebody on that med and you question, you go, oh, I don't know why you're on this. Check and see if they got COPD, because that may be why they're on it. So. Okay, so there's the new phosphodiesterase inhibitors that are called PDE4, and they decrease inflammation, which decreases damage to lung tissue, severe COPD, and you can't use it in asthma. Now, one of the things I want to mention with decreased damage to lung tissue, with asthma and with COPD, inflammation it ruins what they call the membrane basement, which is the membranes that line the bronchial smooth muscle cell. It damages that. Every time you have inflammation and you have white cells and what you end up with is a lot of scar tissue. And we call that remodeling, pulmonary remodeling. And the more remodeling that happens, the less compliant your lungs are from an elasticity point of view. So if you can decrease inflammation, then you will decrease damage to lung tissue, which is important. The medication out there that's the new one is called roflumilast. I've not seen it used, but you may have, if in clinical, if you might have somebody with a severe COPD and chronic bronchitis, emphysema, which are the two parts of chronic obstructive pulmonary disease. It has a lot of side effects: diarrhea, reduced appetite, nausea, headache, depression, weight loss. So people, in the literature at least, talk about it's a little hard to adjust to, but you can treat the side effects with other medications. But the whole thing is, can you breathe? And people are willing to tolerate some of these side effects because if it helps them breathe, then that's what matters. Has anybody seen this med used or know of anybody on it or seen it?
No.
I have it. It's fairly new on the market, and I've not seen it used. So, but it is a phosphodiesterase inhibitor, a PDE4. So it's much more specific than methylxanthine group of meds. But again, use is severe COPD. Now, these are prophylactic asthmatic drugs. And there's the chromium, sodium, Ceravent, Titulate. And again, these are only used for asthma. They are inhalers, as you can see. You've seen some of those, I'm sure. What they do, they're a combination of a bronchodilator and a steroid. So that you get the bronchodilation and you get the anti-inflammatory part of this. They are never, ever used as a rescue medication. So if you have a patient in acute distress, this is not the drug to use. In fact, Ceravent has caused death in people that took it that were in acute exacerbation of asthma. So what this drug does is that it creates a protection around the mast cell in the body. So it like coats it. The mast cell is the cell that houses histamine. When you have a trigger of some sort in an asthmatic attack, you set off an allergic reaction where that allergic reaction, the antigen antibody reaction, attaches to a mast cell. The mast cell itself breaks down and allows histamine to be released. And then histamine goes in and causes all sorts of bronchoconstriction and other problems. So, and then you can't breathe. So by giving these medications and you take it the same time every day, like a lot of things, not an acute attack, you just take it daily, it creates a protection around the mast cell so that when the antigen antibody comes, the mast cell does not break down and release histamine.
Thank you.
Is that, do you want me to say that again, or are you okay with that, or? So that's how these medications work. They're usually only for asthma. They're taken every day, and they protect the mast cell from being attacked by the trigger that you would have for asthma and causing the release of histamine. And release of histamine will cause anaphylaxis, including bronchoconstriction. But for asthma, it's the bronchoconstriction that we worry about. So these are not medications that you would use for people that have like an allergy to bee stings or something like that. That's not what these are for. These are specifically for asthma.
So it's kind of like a Benadryl, but not.
Yeah, I mean, you know, you think about it like that. Yeah, yeah. So they're prophylactic. So you take it every day And it's part of the asthmatic regime, if you will, and I think you probably, have you studied that in 231A? I know not everybody's in 231A, but they do respiratory. They talk about the gold standard for medication administration for asthma. And these medications are part of that. Okay. You know, the pretty much last very important medications, because steroids are the anti-inflammatory. And almost everybody with any kind of COPD, asthma, any kind of respiratory issue is usually on a steroid of some sort. Now, these are just, you know, these are some of them here. And basically what they do is they block that whole inflammatory reaction. Now, ordinarily, you have in your body, you have cortisol that does that. X is a sort of a natural anti-inflammatory, but people with COPD and asthma need more. So they'll give them a supplemental steroid. It's important with steroids from a nursing perspective that you wean them on and wean them off. You wean them on and wean them off. The reason being, once you start giving supplemental corticosteroids, your adrenal gland stops production internally of those. Because remember, it works on a negative feedback loop. So the body says, well, I don't need to make any cortisol because there's enough floating around in here. So you always wean them on and wean them off.
That's the same thing as titrating, right?
Yes, titrate, yep. Mm-hmm. Yep, it is. So these are just some of and when you see things like, you know, court, zone, those are all endings for corticosteroid meds. Prednisone, Solumedrol, Solucortef. Again, these are all corticosteroids. They come IV, PO, they're inhaled. There's lots of routes for them. But remember, whatever you do, you need to put them, wean them on, wean them off. It's very, very important that you do that. Now, so, and you probably have there's a lot of people on prednisone PO, COPDers. They take it every day, 5 milligrams, 10 milligrams to help maintain the anti-inflammatory process. Solumedrol and Solucortef are IV meds.
So, like, if they're getting into Solumedrol, but not like on a daily basis, because that's Solumedrol right here on the screen,
Mm-hmm.
to, you know, mix it and stuff like that and inject it. But like, aren't they only allowed to have like that large dose, like 3 or 4 times a year because of their liver or kidneys?
Not that I don't know of any liver or kidney issues. It's
like in that large dose, like if it's the 125 milligrams,
mm-hmm.
you know, like not for like COPD, let's say they came in and they had like, I don't know, some type of infection or something, and they wanted to give them a steroid.
Uh-huh.
Not something they would take, you know, every day.
Mm-hmm.
Because you said that the prednisone would be like 5 milligrams or something.
Yeah, that's long-term use. That's a chronic long-term use of steroids for like COPD. Yeah. In the IV would be someone that came in and that we needed to get an anti-inflammatory right away, or somebody that was NPO. They couldn't take a PO version, so you can use it that way. But even with that, you have, you know, short-term use isn't as much of an issue as long-term use, and I'll show you
Because of weight gain and all that.
Yeah, yeah, because that, which is my patient care concerns. In terms of corticosteroid, preferred long-term use treatment for children, because it does help with children with that, with asthma. For pregnant women, it works well for uncontrolled asthma, breastfeeding. Inhaled, okay to use, but not systemic. And with older adults, inhaled is the best to use. Now, the other problem with corticosteroids, and I didn't put a slide up here, but I probably should add one, is the side effects. And have you studied Cushing's syndrome yet? So for you, those of you probably in 231A, Cushing's syndrome is a real problem from long-term use of corticosteroids. It causes moon face, causes hair thinning. It increases appetite. It causes patients' mood disorders to change. Because it's an anti-inflammatory, you're at higher risk for infection. So there's all sorts of things with corticosteroids that are a problem, and they can produce Cushing's syndrome. So you have to monitor the patient carefully for that. Once you take them off the corticosteroid, the symptoms go away. But they cause a lot of weight gain, bloating, increased appetite, the moon face, buffalo hump, to get a fat pad on the back of your
Neck.
backside right there, and they call it a buffalo hump, kind of thing.
Aggression, agitation. It causes aggression and agitation.
Yeah, it sure does. It causes a lot of mood kinds of things. And, people get angry, things that you wouldn't anticipate happening, but they do have that with corticosteroids.
I can't take Solumedrol because it makes me have really bad muscle aches.
Yep.
Same thing with prednisone with my youngest. She has the same problem.
Yeah. And it does. It has a lot of side effects. But it's the drug of choice as an anti-inflammatory. And a lot of people are on steroids of some sort. So, and not only for COPD or respiratory, there's a lot of other medications, other diseases that steroids are used for.
Yeah, I was given it for allergic reaction, and my daughter was given it for croup.
Yeah.
Don't they have long-term effects too, because they thin the skin for older adults?
Yeah, it thins the skin, and then their skin breaks, and they get all sorts of, they get bleeding, and they get a lot of under the skin kinds of, brown colored, and yeah, it's not a great med to use. And that's why they say with older adults, the inhaled is best rather than the systemic. Works better for them. Okay, any other things with corticosteroids? I got one more slide to show the inhaled versions. So
the breastfeeding, inhaled okay to use, but systemic contraindications. What would those contraindications be?
Because it crosses, it's excreted in breast milk, so that the infant would get Cushing's, could develop Cushing's disease from it. And you sure don't want that going on, so. Oh, everybody okay here? So inhaled corticosteroid, you can see that, there's lots of them, and they're mostly all from meter dose inhalers. So again, you take the bronchodilator, and then you take the corticosteroid with that. The other thing with steroids, if you're going to use inhaled corticosteroids, make sure that the patient rinses their mouth out after they take it, because what happens with this is you get thrush from it. And so make sure that they understand that they need to rinse well, and also, to watch for thrush, because that's one of the things that happens with this medication.
Is that like a white coating in the
Yes.
mouth?
Yep.
Okay.
Yep. Mm-hmm. So, okay.
Would the spacer help prevent thrush, or is that just
With the what? I'm sorry, I didn't hear your.
a spacer
A little bit, yeah, but you're still getting the stuff in the
in
mouth.
your mouth?
Yeah, you're still getting it in there. Your spacer does help a little bit, but the idea with the spacer is, that you
Get
get more
more in your
medication,
lung.
you get more meds. So,
Yeah.
but it's important that they do, have good oral care with if you're going to use inhaled glucocorticosteroids because of that. So watch for thrush with that. Okay, is everybody okay with that? So remember we talked about combination meds. Now these are, Advair, Combivent, Burel, and what these are is the again the fluorocortisone, which is a steroid, and samiloril, which is a salmeterol bronchodilators. So you take these combinations so that you don't have to give the patient two medications. So they suck them in. And they get their bronchodilator and their anticholinergic all in one.
The only downfall would be like if they're like insurance. They don't,
Yeah.
right? You'd have to
Yes.
break it down and do
Yep.
different meds, right?
Mm-hmm. Yeah. Insurance is a real problem, and it depends on what you got and who will take what and all of those kinds of things. So it makes a difference. So. Any questions about combination meds? It's nice because the patient only has one to think about rather than two. And again, the more simple you can keep it, the more compliant the patient will be
Right.
with medication. So the last slide is a new medication. Is these new medications that stimulate the immune system, and they're called monoclonal antibodies. And they're an antagonism of IgE, which is part of the system, the antigen antibody system that causes allergic reactions. So it's indicated for allergy-related asthma, and you give it sub-Q every 4 weeks. And again, it's for people with severe asthma that have, maybe it's an allergy to ragweed or something that just sets them off and they can hardly manage. So that if you can antagonize IgE, then you can stop the mast cell from breaking down. So it's sort of on the same concept of those other meds that we talked about, the Ceravent and some of those, although this does not have any anti-inflammatory action to it, or does not have any steroids. This is just simply, you give it as an antibody. The antibody attaches and antagonizes IgE. IgE cannot attach to the mast cell. Therefore, the mast cell does not break down and you don't release histamine.
So it's given like the same thing like any other allergy injection?
Yeah, very similar to, yeah. Mm-hmm. Yeah, and because all allergy injections sort of function on that same premise.
Okay, thank you.
Which is prevention of the release of histamine.
And it's the same dose every 4 weeks? You don't touch?
Yep.
Okay.
Fairly new med, so I haven't seen a lot of it, but
Yeah, I'm just trying to like get it in my head because it's kind of like an allergy medicine, like injection, and sometimes allergy medications, you know that since and you're titrating up on it every week when you go in to get it,
Mm-hmm.
but this one's not.
Yeah, that's what I understand. Like I say, it's a fairly new med, and so
Okay.
I'm not seeing it used. But
So this med is a mast cell stabilizer.
well, it not technically. What it stabilizes the mast cell. It doesn't allow the mast cell to break down because you antagonize IgE. So it interferes with the ability of the antibodies to attach to IgE, then attach to the mast cell. So it does it in a different area. The end result is the same, but the where it does it is different.
Okay.
Because an antibody and an antigen have to attach to the mast cell for the mast cell to break down. So those other meds, Ceravent we talked about previously, they stabilize the mast cell. So the antibody and the IgE can't attach. This antagonizes IgE, so you don't even get it so that it's to attach to the mast cell.
So could you use both those medications together then because they act differently, or
I don't know the answer to that because like I say,
okay.
this is a fairly new med and I don't know if people are using this and Ceravent. I don't know. That's a good
Okay.
question.
I know what you mean because you said that they both have the same end results, but they act differently. Like,
Mhm.
like
Yeah,
how
where they act is
ibuprofen
different.
and Tylenol both have, the fever reducing and pain, reducing effects, but they act differently. And sometimes you can take them
Mhm.
together to help increase the effects, or not increase, but maintain, I should say, I guess, because you could take every other dose of Tylenol and ibuprofen to keep a fever down or pain or whatever.
Mhm.
Like, I don't know if this and the other one could be used like that.
So that is sort of the end of the respiratory meds part of this. Does anybody have any questions? Um, there were some questions. I think you have them. They were in your packet. They're called questions for respiratory drugs. And I think there is 10 of them. And I thought I'd go over those. I'm going to see if I can find them on my thing here and try to get them loaded for you. Yes, no, do you see those okay? Oh, my knee's not spelling. Can you see those or not?
Yeah.
Yeah? Okay, let me just go down through them. So, so a client receives treatment for a respiratory condition through aerosol therapy. The nurse explains the major advantage of this type of therapy is that.
B.
Actually, the answer is A. And the reason is because when you take something inhaled, you don't get as many systemic effects as you do if you give it PO or another route of administration. Okay. Agua. Number 2, a client is using a beta adrenergic agonist for the treatment of asthma. The nurse teaches that the drug action of this drug is
B.
B. Yep, relaxing bronchial smooth muscle, thereby causing bronchodilation. You got that. Great. That's good. Number 3, client teaching for clients on long-term therapy with beta adrenergic agonists for treatment of asthma should include
A.
D. What happens is you develop tolerance to these medications over a period of time. And sometimes you need to take them off one and try another to, again, stimulate the whole, the body just gets used to having those on board. So they don't work as much. Number 4, 35-year-old woman, Atrovent, treatment of asthma. Interventions include
C.
C, yep. Inability to urinate. Yeah, that has because it's an anticholinergic. Anticholinergics will make you blind as a bat, mad as a hatter, red as a beet, dry as a bone. I think that's the ones. Anyway, so what happens with that is an anticholinergic will take away the stimulation of your bladder to feel like it's full. So keep in mind when you give a patient an anticholinergic, you're going to get those other effects. Again, it blurs their vision, blind as a bat. It makes them mad as a hatter because you've disrupted the whole sympathetic autonomic nervous system. Dry as a bone because it dries up a lot of the secretions. And red as a beet because it does cause some vasodilation. Okay, everybody okay with that? Despite a long history of asthma, your patient continues to smoke a pack of cigarettes a day. During theophylline therapy, you would expect to administer
A.
That's right, higher normal dose. Remember, nicotine and theophylline compete for the same receptor, so you have to give them a higher dose. Patient teaching for patients receiving inhaled steroids includes
Rinse your mouth out after the.
Yep, A. Yep, rinse your mouth out. Yep. Patient returns for a checkup after beginning a regime of Accolade for asthma. Which of these findings would alarm you, the nurse, the most?
C.
Actually, C. The whites of the eyes are yellowed.
Jaundice.
Jaundice, a little bit of jaundice with that. Your patient has severe persistent asthma that is not controlled by inhaled steroids. Which of the following should be documented before initiation of Zolar therapy?
B.
D. Positive skin test for perineal allergens, or perennial kind of thing. Perineal, God, I don't spell that right. So look at for allergens. I was just studying about those new diabetic meds that cause all those perineal infections that they're having trouble with. So, kind of thing. I was working on that kind of thing. So for the perennial allergens, so make sure that they, so that you're given the right med for the right problem. Your patient has exercise-induced asthma. Healthcare provider has just prescribed chromium Intel. Patient education should include instructions to
C.
Absolutely.
9 to 15 minutes before.
Okay, number 10, you are the nurse providing a nebulizer treatment for acetylcysteine, which is Mucomyst, for a patient with bilateral lower pneumonia. Which of the following should you remember while administering this therapy and caring for the patient?
The D.
A D, yeah. Remember, acetylcysteine is that sulfur stuff, and it collects on their face and it makes their face sticky. So make sure that you wash their face after they get the med.
Can we go over number 1?
Yes, let me go back to number 1. Oop. Advantage, okay. And I got a rationale here, just thinks I can read you the rationale for this.
Because I
This is-
thought that the limited systemic side effects were a result of the medication being delivered to the site.
Okay,
Like
I'll read you the, okay, yep. Let me read you the rationale for that.
Thank you.
Okay, an aerosol is a suspension of minute liquid droplets or fine solid particles in a gas. Aerosol therapy can give immediate relief for bronchospasms or can loosen thick mucus. The major advantage of aerosol therapy is that it delivers medications immediate to the site of the action, thus reducing systemic side effects. The main disadvantage is that the precise dose received by the client is difficult to measure because it depends on the client's breathing pattern and the correct use of the aerosol device.
So it says both of them, doesn't it?
Yeah, it does in that, yeah. The major advantage is that it has no systemic effects, but delivers the medication, yeah. I would say A and B both for that one, actually. You're right. I think
Yeah,
when you
thanks.
read the kind of thing to it, it kind of, yeah, huh. I would say I would go with A and B actually for that.
Thank you.
Uh-huh.
So
you.
select
Good
all
point.
that's select all that's are applied or whatever.
Pardon me?
Kind of like a select all that apply.
Yeah, kind of thing. C and D wouldn't be good answers, but yeah, it would be, it does have limited systemic effects and it does deliver the medication to the site of action. So I would say A and B both. Not C and D because it does require skill and it's not safe for everybody. So. Any other questions about the respiratory medications? Is everybody okay with that?
Our quiz next Friday will be over this then?
Yes, it will be on this as well as what I'm going to introduce to you for cardiac here in a minute. So we'll have some, because we still have an hour. So I'm going to start cardiac, but I'm going to give I gave you a few minutes break because it takes me a few minutes to load the cardiac and get that all together. So why don't you take like a little 10-minute break, get some coffee, do some stuff, and we'll convene at 10:05 and talk, or excuse me, 11:05 and talk a little bit about some cardiac things. Okay?
Sounds good.
Okay, is everybody back okay? One of the things before we start, I wanted to share with you that this was in the newspaper, Watertown Daily Times the other day, and I cut it out because I wanted to just kind of share this with you because you don't think about it sometimes, but this was this doctor, oh, what's his name? To Your Good Health. I don't know if you can, it's Dr. somebody, and he always has an article in the Watertown Daily Times. But anyway, this lady sent a thing in, and she said she'd been on been to the eye doctor, prescribed a Combingen eye drops for pressure in her eye. I have asthma and should not have been prescribed this drug. Since I stopped taking the eye drops, my breathing is slowly returning to normal. And he replied that Combingen is an eye drop that contains a beta blocker. Beta blockers are effective for the elevation of eye pressure, which is a major risk for glaucoma. Enough of the beta blocker can be absorbed into the system, the patients can experience side effects. One of the most common effects are exacerbation of asthma and slow heart rate. So that, if you have a patient that has been on some meds and then all of a sudden is having difficulty, check things like, are you taking any kind of eye medication or things like that? Because a lot of those eye meds are beta blockers to reduce intraocular pressure. So I just thought, a little tidbit I wanted to kind of share with you about that to look at. So I'm going to start a little cardiac here. And again, I talk a little bit about normal pathos and those kinds of things because I think it helps you see how medications work and why you may or may not have side effects based on that. Because I think if you understand the pathophysiology of the med, you understand the action of that category and the side effects and how patient teaching and how it affects individuals. So the next thing we're going to talk about here is cardiac. So to look at cardiac cell structure, again, we're just talking about one cell here. So the cardiac cell is called, and you probably remember this from A&P, is called the myocardium. That's the actual muscle part of the heart. The sarcolemma is the cell membrane. And then between each cell is these sort of darkened areas, which are called intercalated discs. These intercalated discs are sort of like the Elmer's glue that hold the cells together. And they also help with electrical transmission. Also within the cell, which is the important part of this, we have A bands and I bands. The A bands are the darker bands, and so they're thick filaments right here, and they have myosin in them. The I bands are the lighter bands, thinner fibers, and they have actin in them. Okay, so we have two bands within the cell. So the cardiac cells, the myocardium, the cell membranes, the sarcolemma, and the intercalated discs are around the cells that sort of hold those cells together, and they help with electrical transmission from one cell to the next cell. And then within the cell, there are the two bands, the A bands, which are the thick myosin filaments, and then the I bands, which are the thinner actin filaments. So when we talk about myocardial excitation, contraction, coupling, it is a three-step process. And one thing you got to remember about the heart, when we talk about the heart, we always talk about two phases of it. We talk about that it has an electrical component and it has a mechanical component. The electrical component is the movement of sodium and potassium across the cell membrane. That's the electrical component. Now, that's all good and wonderful. The electrical component and the movement of that sodium and potassium causes waveforms, which you're used to looking at on the monitors. You're actually seeing the electrical excitation of the heart when you see the PQRST part of that. And while we need PQRSTs, we also need that electrical to be converted to mechanical because you need a contraction to pump the blood. So it's important when we start looking at medications related to this that you understand that most of the medications are related to electrical part of the heart. They alter the sodium and the potassium across the cell membrane so when you change the electrical excitation, you change the mechanical contractile mechanism. So myocardial excitation has three phases to it. It has a polarized, a depolarized, and a repolarized part. So I'm going to try to draw this out on the whiteboard for you. I hope I can do this. So if you look at a cardiac cell, oh man, it's really bad. Inside that cell, there is potassium, and on the outside of the cell is sodium. So it's, and I won't draw them, but they're all around. So you got potassium on the inside and sodium on the outside. Now, one of the things I just kind of want to, because I'll draw more of them here, is that just notice that there's more sodium on the outside than there is potassium on the inside for the moment. On the cell membrane, or the sarcolemma, sits calcium. All these pluses, you know, I'm too good at this here, okay? So you have three ions in a cardiac cell. You have potassium on the inside, you have more sodium on the outside, and you have calcium on the cell membrane. When you have a difference between sodium and potassium, they're not equal, you set up an electrical difference or an electrical charge. When that happens, the cell is said to be polarized. Okay, now we're polarized. Because you have a difference, you have more potassium, or excuse me, more sodium on the outside than you do potassium on the inside. So you set up an electrical difference here. When that happens, the cell is polarized. The next phase is depolarization. And what happens is you have these channels on the cell, sodium and potassium channels. And this is calcium down here. I'll just draw it out of the way here. So this is a calcium channel. So during the phase of depolarization, because of this electrical difference, it's sort of like the grass is greener on the other side. People go, hey, these ions, look at it, they go, you know, I'd rather be on the outside than the inside. So what happens is potassium goes out the potassium channel. Sodium comes in on the sodium channel. And calcium moves off the cell membrane into the cell. Okay, so this is depolarization. It's hard to write with depolarization. So a stimulus comes along, you know, you sort of poke it with a stick, cardiac cell. A stimulus from the SA node. It starts a whole process of depolarization because these cells carry a charge, and the whole idea of the cell is to become equal. Now, you don't want that to ever happen or the patient will die. So you want to maintain this electrical difference all the time between these cells. So this cell is charged and it's ready to receive a wave of, or a stimulus, if you will, from the SA node. So the SA node says, here it is. So the potassium moves out of the cell through the potassium channel. The sodium moves into the cell through the sodium channels, and calcium moves into the cell. Now we have more sodium on the inside than potassium on the outside. So do you think they're happy with that? No, they're not, just so you know. So after depolarization, we repolarize. Which means the potassium comes back into the cell. The sodium goes back out. And the calcium goes back to the membrane. Okay, so that's the electrical part of this. So a polarized, and once something is repolarized, it goes right back to the state of being polarized. So this is a continuous process of this whole electrical phenomenon. And when these occur, when this whole polarization, depolarization occurs, it's where you get the waveforms of P, Q, R, S, T. It's this, when you put the electrodes on the patient's chest, it's picking up these electrical differences, and that's where you get the waveforms. So a polarized cardiac cell has more sodium on the outside than potassium on the inside, so it's charged. When the stimulus comes along, it causes the potassium to go out, the sodium to come in, calcium to move inside the cell. Then it repolarizes, so it's ready for the next stimulus. Potassium comes back in, sodium goes back out, and the calcium goes back to the cell membrane. So that's the electrical part of this. So let me go back out to the slide for a second. So that's the excitation phase of this. So the cell is polarized, it is then depolarized, and then it is repolarized. And that is the movement of sodium, potassium through channels to create that effect. So the next phase of this is mechanical activation. And we talked about those actin and myosin filaments. So what happens with that, again, I'll try to go back out to the whiteboard. Hopefully that helps you a little bit. So, and I'll just sort of draw it down here. So here's the cardiac cell. And we talked about the filaments. So these are the thinner ones, which are the I bands. And these are the darker ones, which is, I'll just draw them a little bit longer, but anyway, that's there. And these are the A bands. And the A bands contain myosin. And the I bands contain actin. So what happens with this is that calcium, remember we talked about calcium coming in through the calcium channel? Calcium comes in through the calcium channel and it sits on actin, or sits on these I bands, causing the release of actin, okay? Myosin bands, when that happens, produce ATP. What is ATP? Energy, yeah. So during this phase right here, okay, this is sort of like right in here. We said the calcium moved into the cell. The calcium moves into the cell and sits on the actin filaments. That produces these A bands to produce myosin, which is converted into ATP, which gives you energy. You must have energy for a contraction to occur.
Could you
Repeat
say
that one more
that again?
time?
Yep. So you have calcium coming in through the calcium channel, and it sits on actin filaments, which then stimulates myosin off the A bands to produce ATP, which is energy. Now, what happens with that when you get the combination of calcium on actin filaments and ATP available for energy, what that does is it causes these bands to slide over one another. And when those bands slide over one another, you get a contraction. So again, when you get the contraction, then you have step 3, which is contractile mechanism. Okay, so step 1 is electrical activation, which is the sodium and potassium moving through the cell membranes. Polarization, depolarization. Once this process right here occurs, this depolarization process, and the calcium moves into the cell, it moves on actin filaments. Then energy is produced through ATP, which gives you the third step, which is contractile mechanism. And they'll slide and you actually get a contraction. When you get a contraction, that is mechanical. So it's this process that converts electrical to mechanical, the movement of calcium on actin filaments. Once that has happened, then repolarization occurs. So you can start the whole process again. So this is electrical. The electrical gives you the PQRST. The mechanical gives you a pulse that you can feel. So electrical, this movement of sodium and potassium across the cell membrane is PQRST, the actual waveforms that you see. When you get to this part and calcium moves to the actin filaments and energy is produced, you will get a mechanical reaction, which is a pulse. After contraction has occurred, repolarization occurs. So you can go back and start the whole process again. So this happens for every pulse that you feel or hear, apical pulse. This is the process that's going on. Do you have any questions? The only other thing that I'll at this point share with you is these calcium channels are regulated. They open and close through the activation of beta 1 receptors. So calcium channels are regulated by beta 1 receptors. And I sort of think of it like I think of calcium channels like a garage door, and beta 1s is the garage door opener. So stimulation of beta 1s opens calcium channels and allows more calcium to go into the actin filaments, hence why we get an increase in heart rate.
So what happens when someone has like a weak pulse? Like what causes that?
Yeah, that is more likely related to, several things can happen with that, with a weak pulse. A weak pulse might be the fact that the blood volume is low, like they're hypovolemic. It also could be related to heart failure. Remember I talked about those intercalated discs? Let me just kind of, as long as I'm on a whiteboard, this is a cardiac cell and another cardiac cell here. This intercalated disc occurs right here between cells. And again, I said it was the cell, it was that intercalated disc that held the cells together like Elmer's glue, and also allows electricity, or that action potential, that polarization, depolarization to travel, sort of helps it get from cell to cell. People in heart failure have these intercalated discs, they're torn or stretched. Once that happens, they cannot be repaired. So that leads to less ability of the heart to have a good contraction, which will lead sometimes to a weaker pulse. So it can be hypovolemia. It can be heart failure because of torn intercalated discs. It can be medication related too, and we'll talk a little bit about some of that. So. Questions about that? So everybody's okay with polarization? The stimulus comes from the SA node. Depolarization, potassium moves out, sodium moves into the cell, calcium moves to the cell membrane, off the cell membrane into the cell, plops itself on actin filaments, which then produces ATP for energy. So you get a contraction, and then you get repolarization for the next event to occur. So you get electrical, which is the waveform, and mechanical, which is a pulse. Questions? Anything anybody wants to? Okay. So those are, we talked about the myosin and actin filaments. That's what happens. So the calcium sits on actin filaments. ATP is produced by myosin filaments. And then they mesh together and you get a contraction. So that's mechanical activation. So you've converted electrical to mechanical. So you get a pulse. And then the contractile mechanism is just, the actual contraction. And you can see where those things slide over one another. And that's the contractile mechanism. The cardiac system has a lot of electrophysiological properties to it, and I'll just talk about 3 of them here to look at this. The first one is automaticity. Cardiac cells have an ability to produce a contractility, to be stimulated, so forth, all by themselves. They're automatic. And that's why it allows them for a heart transplant, because you actually, the cells have that ability to be, to contract on their own. The problem, you know, and that's great. The problem with that is that it produces a lot of arrhythmias or dysrhythmias, cardiac dysrhythmias, because one cell may be having a bad day and it produces all sorts of ectopic beats. But automaticity by definition means that the cell can depolarize all by itself. Conductivity refers to the ability of the electrical impulse to be conducted from one cell to the other. We talked about that being part of the intercalated disc system. So if you stimulate one cell, it goes to a whole bunch of cells. So they can conduct from cell to cell.
Can you say that
So-
again, please?
Pardon me? I'm sorry, I missed somebody asked a question, I missed it.
I was just wondering if you could repeat that.
Oh, conductivity, sure. Conductivity refers to the ability of the electrical impulse, if you will, to be conducted from one cell to the next cell through the intercalated disc system.
Thank you.
Sure, no problem. The third section of this, or the third electrophysiological property, is that of refractory. Refractory means rest. And clear all drawings. So with refractory, what happens is that there's two different kinds of refractory. Remember, that means rest. You have absolute refractory. And you have relative refractory. With absolute refractory, what happens is the cell cannot be, not be stimulated, cannot be stimulated. It's in a rest period. With relative refractory, it can be, and I'll draw them down below here in a minute, can be, but with a bigger stimulus. So a bigger stimulus. So let's look at this refractory by cell here. Remember, we talked about the sodium potassium setting up an electrical difference. If there's a minute millisecond in the heart where when the potassium, potassium goes out and the sodium comes in, that the cell is equal electrically. When the cell has an equal, that millisecond, when you have just that, it's equal, it has no charge to it. So it's in absolute refractory. You cannot stimulate it. And it's only a millisecond. I mean, it's not like a very long period of time. Relative refractory sort of happens, my cell's got a bump in it. Oh, geez, that's bad. Happens on a little bit before and after absolute. So here's your absolute right here, where it's absolutely equal. And then on both sides of that, you have a millisecond of refractory, where it can be stimulated, but with a bigger stimulus. So when it's in that absolute refractory period, it cannot be stimulated because there's no electrical charge. That is a safety feature in the heart, because if you didn't have some kind of a rest period, if you had somebody with a lot of dysrhythmias, your heart would go haywire. I mean, it does already without, So a lot of these anti-dysrhythmic medications that we're going to talk about next week, not today, talk about increasing refractory periods. So if you increase refractory, increase the length of time of the rest of the heart cell, and a stimulus comes along, the cell says, nope, I'm in refractory, I can't be stimulated. That helps control arrhythmias or dysrhythmias. So refractory plays a role in protection for heart cells so that they can't be stimulated unless they're out of refractory. Does that seem reasonable? Okay. The next thing rather than, let me not go back to the thing, I'll just clear all the drawings here. And I'm going to draw the cardiac conduction system. Oh, it's not a good heart. Oh, geez. Anyway, can't get a little bit different. So up here in the right atrium is your SA node. Sinoatrial node. And again, you probably remember this from A&P, I hope. Out of the SA node comes these intra-atrial pathways. Get them all collected here down. And they all meet at the AV node. AV node stands for atrioventricular. It's where they come together. Okay, so the SA node then they travel these intraatrial pathways through the atria, and all these collect at the AV node. Then off the AV node is the bundle of His. Okay, that's the bundle of His. That comes off the AV node. Out of that comes the Purkinje fiber system. And these travel through the ventricles and help carry the impulse to the ventricles. So these are the Purkinje fibers. Purkinje fibers. So when we talk about these cells, this is the cardiac cell we drew before. So what happens when the SA node itself depolarizes? It travels along these intraatrial pathways and hits the cell. That's the stimulus we talked about. It's bang. And the cells that are polarized, they're waiting for their stimulus. They start to depolarize. And it travels from cell to cell to cell. And there's cells all through here. And it's very, very quick, very rapid, cell to cell to cell to cell to cell, all over the atria. Cell to cell to cell to cell. So all of the atrial cells are stimulated and they depolarize. When the SA node depolarizes, it produces a P wave. That's the electrical thing you see. So the SA node, so the P wave is SA node depolarization. Now they refer to it as the, even though it all happens all over the atria, they just call it SA node because SA node is known as the pacemaker of the heart that sets the rhythm. So they just call it SA node depolarization. And when that happens throughout the whole atria, you get a P wave. Looks like that. All of these eventually end up at the AV node. This whole thing sort of comes to the AV node. The AV node is I call it like a depot, like a train depot. All of these impulses are coming and they need a place to collect, to gather themselves. So they collect at the AV node. The AV node has no electrical anything except to act as a depot. It says there, I'm there, I'm at the depot. When everything is collected, so there's no activity, electrical activity, so what you get is a straight line. It's just a collection point. Then it shoots it down through the bundle of His to the Purkinje fiber system. When that happens, you get the QRS complex. QRS. That is ventricular depolarization. Now, sometimes you don't get a Q, sometimes you don't get an S, depends on how you have the electrodes, but they call it a QRS. But sometimes it's only an R way, sometimes it's only part of something, but it's always referred to as the QRS. So as this whole depolarization process occurs, you end up electrically with a P wave, AV node collection, QRS complex. So the P wave is the atrial depolarization. The QRS is ventricular depolarization. The last thing is the T wave. That's the T. The T wave is ventricular repolarization. Okay. So when you're listening to a heart, apical heart rate, what do you hear? S1, S2?
Yes.
Okay. So what you have with that, so if you think about that, and that's closure of the valves, but anyway, for our purposes. So the atria depolarize, Then right after that, you get atrial contraction. S1. So electrical, mechanical. Oops. Then you get ventricular depolarization. And right there, you get S2, which is ventricular contraction. And then you get T wave, which is ventricular repolarization. So you can start the whole process again. When you're done, I'm going to erase this one and kind of draw a little bit more out. So, but I want to make sure you can, if you want to copy it down, or it'll also be in the recording as well. So hopefully we'll have all that.
You said that the atrial contraction was the S1.
Yes.
And then what was the S2?
S2 is ventricular contraction. And that has to do with closure of valves. The actual, it's not the actual contraction. It's what you actually hear in S1 and S2 are the valves, aortic and pulmonic, and mitral and tricuspid. So, okay. So is it okay if I erase this, clear it, and then I'm going to draw out a whole thing here? Is that everybody okay with that? Okay. So what you have here, I'm gonna try to make it big so we can kind of draw things in between it. So P wave, which is atrial depolarization. P wave is atrial depolarization. Here we get atrial contraction, S1. QRS is ventricular depolarization. Ventricular contraction, S2. T wave is ventricular repolarization. So that is one waveform, one heartbeat. I just started questions. Any questions? That's all I'm going to do today. I just kind of wanted to stop for a minute and make sure everybody was okay with what we have here. Any questions? The quiz next week will be leftover respiratory and what we covered in cardiac today. It will be 10 questions. It'll be on Respondus. It'll be multiple choice.
What slide did we technically go up to in the cardiac?
The slide actually is, let me go back. I'll show you the slide technically here. Stop share. Actually, right, just to this part right here. I want to, you know, I'll talk a little bit about waveforms, you know, like I just gave you, that picture I just gave you, but there will not be anything on ectopic beats or arrhythmias at this point, okay? I just want you to have some basic understanding of depolarization, repolarization, cardiac conduction, and what the waveforms mean. And, you know, contractile mechanism, you know, polarized, depolarization, repolarization. So it will be just to this will be after we talk about normal waveforms, you know, PQRST, that's the end. And next week we'll pick up with all the cardiac meds. Questions? I got some email from some of you. I'll have to go in and related to the quiz, problems on the quiz. I'll have to go into Blackboard and see what I can do with that. But thank you for the email so I can check on them. So I'll look at that. Thank you. If you have questions, please send me an email. A couple of you did last night. I was very glad to get them. So if you have questions or things, please, that's okay. Glad to do that. I'll try to get this loaded this afternoon out on YouTube. It's a little bit of a process, but I'll do my best. Any other questions, issues, anything anybody would like to ask? Or
Are you still looking over the exam questions?
yes, we are. Yeah, I
Okay.
am. I haven't. Thank you. I haven't. The problem that we're having, you know, I'll tell you, the problem we're having right now is the fact that I can't see individual exams. So I have no idea what people put for answers. Dean is working on that through IT to figure out how we can go into Respondus and look at individual exams. I have no way. I just have a grade and the fact that you took it. I can't access any other information. You can see them individually, but I can't get to them. So I'm trying to work on that next. Dean and Katie and I are working on that. So we will be making probably some alterations in the grades to those, but I will let you know when we figure out what we did with that. So.
Okay.
I haven't given up. I just am kind of stuck at the moment, waiting for Dean to figure that out for me. Any other things or that anybody would like to ask or say or anything? Any questions? Okay, you're doing well. I want you to know, I know this is not easy. This is hard stuff. It's hard trying to do all of this. So thank you for your patience, your questions. See what we can do, and we'll just keep working on stuff.
Thank you.
Okay, we'll see you all again soon. Take care.
Yes,
Thank
bye.
you. Bye.
Okay, bye-bye.